Hello, and welcome to today's Health IT Analytics webcast sponsored by Actian and Chilmark Research. What's a healthcare data analytics hub and why it matters for value-based care and business models? I'm Vanessa Palmer-Desiato, Project Manager at Excelgen Healthcare Media and host of today's webcast. First, I'd like to thank our sponsors, Actian and Chilmark Research. Actian, the hybrid data management, analytics, and integration company, delivers data as a competitive advantage to thousands of organizations worldwide through the deployment of innovative enterprise-class hybrid data products, fully managed data warehouse cloud services, and IoT edge data management solutions. Actian's Avalanche Hybrid Cloud Data Warehouse flagship offering delivers on-premises as a fully managed multi-cloud service on AWS, Azure, and Google Cloud, and features industry-leading price performance, scalability, and connectivity. Thousands of forward-thinking organizations around the globe trust Actian to help them solve their toughest data challenges to transform how they run their businesses today and in the future. Founded in 2007, Chilmark Research is a global research and advisory firm that is solely focused on the market for healthcare IT solutions. Everything they do is based on their core belief that healthcare information technology plays a crucial role in improving the quality and efficiency of care. They foster the effective adoption, deployment, and use of HIT by providing objective, high-quality research into technologies with the greatest potential to improve care. This laser-sharp focus allows them to provide their clients with the most in-depth and accurate research on the critical technology and adoption trends occurring throughout the healthcare sector. We will begin with a presentation by our speaker and conclude with a question and answer segment. Audience members can submit questions at any time during the webcast using the question tool to the left of the screen. For all technical matters or difficulties, click the help icon at the bottom of the screen. A recording of this webcast will be made available following this presentation. With that, I would like to introduce Louis Carr, Senior Director of Product Marketing at Actian, to introduce today's speaker. Louis, the floor is yours.
Thank you, Vanessa, and I want to thank all of you, regardless of where you are, whether it's the West Coast where I am and it's the morning, or if you're in the Central or the Mountain or East Coast, where it might be afternoon for you, or if you're listening from overseas in Europe and it's the evening. Welcome to our webinar today on Health Cloud Data Analytics, and I hope that you find this interesting, so interesting that you will please place some questions into the Q&A session, because we are absolutely going to leave sufficient time to get through probably at least half a dozen questions. So please place your questions into the Q&A section. Now, as Vanessa said, we have the privilege and pleasure of having Brian Murphy, the Director of Research at Chilmark, speak about Health Cloud Data Analytics hubs and their value in the current market and the trends in that market to create the context for that value. So without further ado, I'm going to turn it over to Brian. But again, we're going to leave time for Q&A, and I will act as the moderator for the Q&A session. So with that, Brian, take it away.
Thank you very much, Louis. And thank you very much for thinking of us and inviting us to participate in this webinar. We're pretty excited about it. It's a great time to be talking about the value of analytics in healthcare. It's a great time to be talking about cloud computing in healthcare, both of which we feel have a tremendous amount of headroom to contribute to better operations, better clinical operations, better financial outcomes, what have you. I've got, just so everyone who was kind enough to tune in today knows what's coming, we've got about 35, 40 minutes worth of material. But just to reiterate what Louis mentioned, we've got a lot of time at the end to answer questions, and I feel like that could really be some of the most fruitful stuff. So please hang in there and please ask any question that might occur to you. As most people know, the healthcare industry in the United States has been going through quite a few changes. I guess the thing that jumps out most about healthcare is just how expensive it is. At this point, at least according to the most recent data, healthcare costs in the United States are eating up something on the order of 18 to 19% of GDP, which is significantly higher than any other country, and certainly significantly higher than any developed country. And that that percentage is only growing, and it's growing faster than most other countries. This is being felt in a lot of places and in a lot of ways in our economy. Ultimately, consumers pay for this. They pay for this in lower wages. They pay for it in premium costs. They pay for it in out-of-pocket costs when they actually go to receive healthcare services. And they are taking note. They're complaining to politicians. They're complaining to healthcare insurers. So there is a tremendous amount of focus on the part of the general public on this problem of growing costs. Most employers are similarly getting hot under the collar about the growing costs in healthcare. And they too are complaining to their insurers, they're complaining to government. So there is this broad consensus that somehow healthcare spending has got to be brought under control. Now, that admittedly, that consensus has existed for several decades, but it's impossible not to come to this idea that is somehow coming to a head here in the next 3 to 5 years. One of the ways that a lot of the payers, particularly government payers, the CMS, is thinking about trying to address this cost growth is to wean the healthcare system off of the dominant way that it's paid, which is called fee-for-service. And more and more payers are introducing these things called value-based reimbursement, value-based healthcare plans. Sometimes you will see it referred to as alternative payment models. And the idea is to reward providers not for the volume of services they deliver, but to reward them for in some sense, for the outcomes, and in some sense for the value that they provide, as opposed to the sheer number of procedures or prescriptions or what have you. And in order for that to make economic sense to these provider organizations, they're really beginning to look at redesigning their care processes, their financial processes, their administrative processes, to more accurately reflect this kind of reimbursement model. It's also dovetailing on something that's been going on for 20 plus years, which is moving care, trying to deliver more preventative care and moving care into what are called less cost-intensive venues. So instead of people being in hospitals, if we can take care of people at home, ultimately that's going to be, and do as good a job. So there's a real bias in favor of doing that. In this kind of environment where people aren't being paid for the volume of services and instead are being measured on the quality of the care that's being delivered and how costly that care is, in that environment, networks of clinicians that do that deliver lower cost and higher quality, are going to succeed. And networks that don't do that will have a slightly tougher time. Another thing that's happening in healthcare is the availability of data is expanding. For lots of different reasons, data is not something that has always flowed freely between the different participants here in health. We recently had a set of new government regulations that came out of a law passed several years ago. Called the 21st Century Cures Act, and and I'll talk about that in just a second. The other thing that is that's happening is the universe of data types is expanding pretty significantly. So we see things like genomic tests, which are beginning to become available based on things that are happening in the research world. That's an example of a data type that most provider organizations are not exactly aren't really set up to necessarily use, but that data is becoming increasingly more available. Another example would be something called the social determinants of health. There's this axiom in healthcare that the things that most affect the health of an individual occur outside the healthcare system. So providers are increasingly interested in getting data about the social circumstances of people and using that to deliver care. There is a new standard called FHIR, which stands for Fast Healthcare Interoperability Resources. It's from a standards organization that has been active in healthcare for 40 years called HL7. That is, and the impetus from that came substantially out of the provider world, but FHIR is being increasingly seen as a kind of a common language across all of healthcare, providers, payers, pharmaceutical companies, device manufacturers, clinical research, literally any participant in the healthcare system, in theory, should be able to use this standard to do what they do better. The other thing that's happening is there's a much greater focus on supporting developers than there has been in the past. In the past, most software in healthcare was delivered as a service, or it was delivered on premises where people mostly just configured things. More and more programmers are becoming involved in building applications and modifying them. So we have in healthcare lots and lots of organizations, and like every other industry, the data is very, very heavily siloized. And that means that there's tremendous duplication of data across inside of organizations and across organizations. And there is a feeling that cloud computing is going to go a long way towards helping to tame that problem and make data more usable for people. I mentioned briefly the 21st Century Cures Act. This is a relatively recent thing. It essentially, but it took 15 years or so to get to the point where we are today. It established the idea that FHIR is something that pretty much everyone in the healthcare system should be using. It requires most of the major players, the provider organizations, payer organizations, to build a set of kind of a minimum set of FHIR-based APIs that should be available for patients, for patient type applications to use, but also for outside organizations to use. So it basically expands on this idea that data, should in some way be left close to where it was created, but that it should be usable in outside organizations in some way, shape, or form. We want to talk a little bit here about this idea of value-based healthcare, this idea of getting away from fee-for-service models of delivery and fee-for-service models of payment. The main players in a value-based healthcare plan are going to be provider organizations and a payer. They are working with both of them are working usually with a fixed network of clinicians and a fixed set of members. What's common across, and there's lots of different variations on these kinds of plans, whether it's CMS-based or commercial insurance, but in general, they kind of fall into two buckets. They can be, it can be for a defined panel or list of patients, or it could be for a particular episode of care. And probably the best known example of a panel-based, value-based healthcare plan is something from CMS called the Medicare Shared Savings Program. Medicare also has a program called the Bundled payments for care initiative. That would be an example of an episode-based value-based program. But what all these have in common is that the payer and provider agree on certain cost and quality targets and specific ways to measure what performance against those targets and of course what the targets should be as well. They also aim to head off certain kinds of high cost utilization, so primarily things like hospitalizations or ED usage. And then at the end of the term, usually a year, a plan year, a calendar year, a model year, the terminology varies from one to the other. The end of the year, if the cost quality, if the cost targets are met, then the provider gets to, and the cost targets are always measured against what fee-for-service spending would have been under the same circumstances. So if you come in under the fee-for-service amount, the provider can get a percentage of that savings. If you come in over, they have to pay it back. And this is this slide right here kind of gives you the crux of how analytics can be used in this kind of context. Let's focus for a minute here on the middle part of this, which is the contract execution. And I must say that if you look at what's available in the market today, a good 80% of the products and services that are out there are geared towards this middle part. It's this idea that a provider or payer can understand what's happening right now with respect to the contract. Are we on track in terms of meeting our cost targets? Are we on track in terms of meeting the quality metrics that are expected under this contract? If we're not, then we need to think about things we can do to modify our processes to begin to perform better. On the left-hand side, which it seems like it really kind of should be the first thing out of the chute, but in reality isn't. It really goes to this idea of looking before you leap. So any organization who becomes involved in a value-based healthcare program would want to use data that they have and try to figure out if it even makes sense in the first place to become part of these contracts. So they could look, for instance, at their historical quality performance and see if the terms that are being proposed to them by a payer make sense, if they are remotely attainable. It would be nice if they could, I think if a lot of provider organizations could understand what other kinds of value-based programs are happening in the market, and are their competitors doing them? And then on the right-hand side, it goes to this idea of kind of stepping back. And trying to figure out more broadly what kinds of clinician networks. So if it's a primary, for instance, if it's a primary care focused value-based plan, if we look across our geography, which 100 or 200 or 300 or 500 primary care physicians could we partner with and who would deliver the kind of care we need in order to meet our particular goals. And there is, I've got to say, so what I've described here is kind of theoretical. If you kind of look at the data that different organizations have at their disposal, it puts them in a position to answer some of these questions better than others. So for example, payers have a truly panoramic idea of everything that has happened with a particular group of patients. In other words, so every time a person goes to anywhere to receive some care, the payer is going to hear about it. So they've got a good idea of the disease burden that might exist in a potential group of patients. The providers, on the other hand, who use their electronic health records, have a much better idea of the specifics of what's going on with any given patient, but it is only with respect to their organization. So they are, because healthcare is so siloized, they do not have good visibility into where patients may have been receiving care outside of their organization. So there is this idea that in order for all of this to work, there has to be a hub. There has to be some way to, for all of these different participants to get a truly panoramic view of what's going on with a particular set of patients and how different clinicians are delivering care. What kind of performance can you reasonably expect from a given set of clinicians? So we've got this idea of a hub that can be used to really leverage all of the data that exists across the healthcare system in order to build better value-based healthcare programs. But I mean, if you're doing that, you are really building something that can be used for a variety of other use cases above and beyond value-based care just for providers and payers. So the goal of something like a Health Cloud Data Analytics Hub is to create standardized, normalized data that can be used for any kind of subsequent use case. So ideally, you would be able to source that data from kind of any organization or any application and perform a whole set of transformations on it. And this, our little, our ribbon here kind of gives you a sense of that voyage from source to use case. In the red, we've got a whole set of things that can and do happen to data between getting raw access to it and making it productive and making it actionable in any sort of analytics and reporting use case. The one thing that we feel like is probably missing a little bit at this point is this whole idea of cloud native. As I think I alluded to earlier, most of what we see, particularly providers and payers, is either run as a kind of a software as a service where there's a vendor who does a lot of this work, or it's done on premises in the case of large organizations. So there is a real opportunity here for cloud native tools to really begin to make an impact in rendering data from its raw, heavily siloed form to its usable form. Why is healthcare data so hard to work with? Well, one of the reasons is the organizations themselves have a really variable capacity for change. So large provider organizations, well, in general, organizations in healthcare are going to be somewhat risk averse. And they also have, the bigger organizations in healthcare have strong IT organizations. And in fact, I think one thing that's changed over the last 5 years is, particularly among the health systems, is we're seeing more and more of them are actually able to put together real sort of data science teams who are really in a position to extract maximum value from the data that they have and the data that they can get access to. They're really in a good position to build AI-based algorithms, for instance, to be used in applications. But as soon as you get outside of the kind of large health systems, that kind of skill drops off significantly. Even in those large health systems, their resources are not infinite. So there's a tremendous opportunity for vendors such as Actian to go in and supplement those organizations and begin to deliver data management type services to smaller organizations as well. Data rights is still something that's a little bit up in the air. in general, the data that sits in provider organizations is seen as highest value. So many other non-provider type segments are clamoring for access to provider-based data. I think in particular about pharmaceutical companies, clinical research, device manufacturers, all would like carte blanche access to that data, and they're not quite, we're really not quite there. Data quality is an ongoing, difficult problem in healthcare. There is not a single integration project or analytics project that doesn't bump up against this in some way, shape, or form. And a lot of this has to do with just the, general data quality issues, but much of it has to do with there are, as you can see on this slide, there's a whole slew of standards, and people adhere to those standards variably. There's a lot of time and effort involved in converting data so that it is any given canonical standard. The data is very complex. There's a lot of different organizations. Patient matching is a continuing challenge. I think one way to think of that is deduplication. It's something that frankly takes up a lot of time and effort. It's not super high value, but it's something that a lot of organizations spend a lot of time with. The skills in general, I mean, if I had to grossly generalize, the skills that exist in most healthcare enterprises are probably closer to legacy than modern, but that works in a great many cases. And finally, privacy and security is an ongoing thing. People are afraid of being subject of some kind of HIPAA enforcement action. And now with the 21st Century Cures Act, there is a certain level of fear about what could happen if you end up being called an information blocker. And this slide, I won't spend a lot of time, this just illustrates how many opportunities there are to kind of mess up data, if you will. There's roughly 1 billion encounters across the healthcare system here in the United States every year. Every single one of those encounters could generate up to 4,000, it can generate more than 4,000 different data elements. And there are something on the order of 4 million people with some kind of a clinical license who are documenting the care that they deliver in one of 100 plus EHRs that exist out there. So there's a lot of opportunities to introduce mistakes, omissions, non-adherent codes. This gives you another another cut at why healthcare data is so complicated. On the left-hand side, we've got the different kinds of data that could exist about one individual. And that's and this is this slide has got it's primarily kind of EHR-based data, but there's in other words, we're not a bank here. This is, a bank might have an account number and, then a series of amounts. These are radically different kinds of observations that can be made about a human being and then recorded in this computer system. On the right-hand side, it gives you an idea of the different organizations who can contribute to or use any of this data. And as you can see, there's a lot of them. And just to kind of gild the lily here a little bit, all of those organizations will have some kind of unique identifier to identify that particular patient or member or citizen. And they will not be the same across those different organizations. So it's a complex environment. And this is one of the reasons that we say that cloud computing is and will begin to deliver a lot of benefits in healthcare and in any segment. I think most people are aware that how cloud works, how the public cloud works. It's sort of a pay-as-you-go. It enables you to right-size your capacity depending on whether it's seasonal needs or what have you. I think our recent experience with COVID-19 had kind of two immediate effects. First of all, volumes in hospitals dropped to nothing, and telehealth, the use of telehealth exploded. That's beginning to tail off a little bit, or tail off quite a bit now. But this is just one example of something that where it's completely independent of seasonality, and it's a little bit of a black swan type of event. But it is true that in the past, most healthcare enterprises have basically bought capacity to handle their peak loads. Cloud lets you get away from that. The other thing that happens particularly inside of large health systems, is there's every single year they go through a budgeting process where, particularly a capital budgeting process, and that is usually the place where hardware decisions are made there, and people have to live with these decisions throughout the year. Cloud really lets you move this whole idea of acquiring capacity into an operating expense as opposed to a capital expense. So it makes things a little bit easier. Cloud also gives organizations access to totally modern, stable technology, and that is not always true in certain segments of the, or that kind of access is not always there in certain elements of the healthcare system. Finally, and this is, I think, pretty important, it gives a lot of things that are available in the public cloud are really geared to the needs of developers and integrators, which, frankly, has not always been a strong suit for traditional vendors in healthcare, whether they're selling stuff on premises or whether they're selling stuff as a service. Now, cloud is making inroads in healthcare. I think there's probably other industries where it's done better. The vendors, most vendors that we work with are, they're using the public cloud in some way, shape, or form. Providers and payers are starting to take note, and they're starting to adopt it. And they want to focus on healthcare. They don't want to focus on IT. I think at the sort of the current path, it's fair to say that we're probably looking at a hybrid type situation for the foreseeable future. I know if you talk to, say, a vendor like AWS, that everything should be done on AWS. I think the more likely outcome in healthcare is that people will retain their service vendors or software as a service vendors. They will probably retain some kind of data operations if that's what they're doing. And they will begin to move certain workloads onto the cloud. So we feel like hybrid is kind of the at least for the next 10 years, the way that public cloud is going to be consumed in the United States. So just to review, the Health Cloud Data Analytics Hub really goes to this idea of any-to-any data connectivity. So regardless of which organization is sitting on the data, regardless of the kind of application it is, regardless of the way that it can be made available, whether it's flat files, database copies, streams, transactions, documents, email, it really makes no difference. Health Cloud Data Analytics Hub should be able to deal with data as it arrives. It's something that you can use to kind of resolve all of your data quality problems. It links data across different applications, different databases, different organizations, any way you'd like, whether you'd like it linked by a patient, by a provider, by a contract, by a cohort, by an episode. That should make no difference. It renders that data computable, enforces, it can take data that is incompletely adherent to a particular standard and turn it into something that is canonically acceptable and that is then computable. And the other thing for analytics is it really is able to aggregate and summarize data and do this in an optimized way, depending on any number of different downstream analytics and reporting use cases you might have. One thing that I don't think I've touched on quite yet is this idea of self-service data management. I think most people are familiar with business intelligence tools, and in the long arc of the development of those tools, what we have seen is that more and more users are able to do more and more things, and they are less dependent on programmers or people who are, with a lot of IT skills to develop reporting applications. One thing that is to some extent missing in the market is a similar capability when it comes to data management. So we will frequently see organizations, for example, every major EHR vendor has a pretty much full-blown data warehouse. And they're great, they do tremendous things with them, but it is too often the case, that somebody comes along and they need 5 or 10 or 15 data elements that aren't there, and the vendor or the IT organization can certainly handle that, but it could be 2-3 months. So in other words, there should be this ability for super users inside these user organizations to be able to go out and figure out where that data is and begin to use it in a relatively straightforward manner and without getting the IT organization involved. And we're starting to see it, but I feel like the industry's got a way to go there. So I have talked a lot about value-based care and using analytics in that, but I want to emphasize that the capabilities that we're talking about here can really be used in many other use cases above and beyond that, can be used in many segments that we haven't talked about, although I've talked heavily about payers and providers. As I have mentioned that there's plenty of other parts of healthcare that are clamoring for access to this data and can use it. Digital health is one example. For people who follow this, digital health is it's kind of an amorphous category, and it's one which has attracted a significant amount of venture capital investment, private equity investment, whatever you want to call it. Most of those companies are going to create new data, or they're going to want access to data that exists. So they will be clamoring for access to this kind of data relatively soon. So these are kind of the benefits that we see. We really feel like something like the Health Cloud Data Analytics Hub can really accelerate innovation, particularly in areas that, that are not necessarily set up to be innovators. This is because it's cloud-based. We really feel like this is something that organizations can use to get better bang for their buck, and they can begin to invest in. They've got money and time to spend on developing those new care models that are more efficient, that produce a better outcome for their patients. Speed is an important benefit here. By pushing, by making data management capabilities more broadly available inside of an organization who really feel like they're going to be in a position to do more with less. And finally, one of the major bugaboos in healthcare right now is something called clinician burden. And a lot of this boils down to how difficult it is to use applications of any kind, including analytics and reporting. And this puts an organization in a position where they're able to deliver more targeted, more on-point kinds of applications. Patients will benefit when clinicians seem to know what their problems are beforehand, and it goes a long way towards can go a long way towards getting payers and providers on the same page and reducing the amount of friction that may exist between them. So I think that concludes my prepared remarks. Louis, if you're still there, do we have any questions?
Yes, we do. I just want to make sure you can actually hear me deliver the questions to you. Oh, good.
Yes, I
okay,
can.
Great. Okay, fantastic. Let me bring up the screen instead of the screen that you were presenting from. So I'm going to start with a question that will then lead into another question we got from the audience. And I need to give you some background for that question. So I was watching recordings of the NBA Finals a couple of months back, and I was cleaning up the kitchen at the same time, and I ran into my pantry to put something on a shelf, and I managed to knock a very large flower vase from the top shelf down on my nose. I then had to run to urgent care, which was closed late in the evening, so I ended up in an ER just to get what I thought would be some stitches. Well, I didn't get stitches. They said it was the only thing you could do is glue it. And that was after 3 hours where they gave me a tetanus shot, which I didn't need because it was glass and it didn't break. And then they also gave me antibiotics. Again, I didn't know why they gave that to me. They then charged me a bill, and I won't say which hospital provider network it was, but they charged my insurance company $2,700. And I'm just wondering how, the insurance company was fine with it. They said, hey, that's what our negotiated rate is with this provider for the care that was delivered. We can live with it, even though it seemed like a very high bill. And so they seem perfectly aligned, the payer and provider in that case. But in terms of a value-based outcome, not so sure. So my question to you is, will a healthcare data analytics hub or anything around applying digital technology to value-based programs make a true alignment of this rather than what just looked like a shrug of shoulders and collusion?
Yeah. So the description. So what you just described to me sounds like fee for service working exactly the way it's supposed to work, which is not great for you. One of the things, I talked a little bit about the expanding data availability. Well, one of the things that's happening right now, as of January 1st of this year, and that date may be a little bit off, so hospitals and health plans are supposed to post on their website their the hospitals are supposed to post their negotiated rates with all of their different health plans. And in general, that has probably not been done. I looked earlier in this year, and the compliance was pretty variable. Some places had it, some places didn't. In the ones who did have it, it was in an XML file, which is great if you're a programmer, but not terribly useful to the average consumer. There are also a whole series of requirements happening over the course of the next few years, which have to do with price transparency. There are some further measures for providers, but health plans are also supposed to publish this same kind of information. So, and this is just a long-winded way of saying it's almost impossible to figure out what something is going to cost beforehand.
Yeah.
And price transparency is probably the worst. It's, of any industry across across our entire economy, it's got the farthest to go in healthcare. But I feel like things are changing. I mean, I do feel like the availability of information like this could potentially head off the kind of situation you described. Now, obviously, you can't negotiate. You can't walk into an ED and negotiate every little thing that happens. They're going to do what they do. But this idea of expanding data availability is, I think, going to make a real difference. And it's critically important that all of these organizations really be in a position to use that data quickly and effectively. So something like the Health Cloud Data Analytics Hub that we've been talking about I think is going to go a long way towards making that data more actionable.
Okay. Well, that actually segues nicely into one of the questions, and I'll read it verbatim from someone in our audience. The question is as follows. For a clinical organization that has never participated in a value-based care program, how can you initiate a conversation or agreement with your payers, either Medicare or private?
So, that's a great point. I have so far talked about value-based care as if it was the end-all and be-all, which is not strictly speaking true. There are parts of the healthcare system who are resistant to this. I feel like in general, most of the healthcare system realizes that this is the future. Now, Medicare and Medicaid, Medicare is administered at the national level, Medicaid is administered at the state level. Frequently, commercial insurers will administer a program called Medicare Advantage. So they'll take a certain chunk of Medicare patients and they will manage the payments. And you can kind of, if you're a provider, you can talk to the payers in your state and figure out which ones are offering Medicare Advantage for the kinds of patients that you see. Similarly, at the state level, most states have some sort of Medicaid ACO type program. And a lot of commercial insurers will do this. I feel like for the most part, if we exclude the government payers, and that's hard to do, but on the commercial side, I think if you ask them about this, I think that they're in most instances they will have people who you can talk to. You can email me if you want. So yeah.
You mentioned this area of this rather amorphous called digital health.
Yes.
Can you give a little bit more of a definition to that? And if it is a category, it must have some ecosystem of vendors in it. And what's the value proposition for those vendors in digital health?
Yeah, I can give you a couple. I do think that the category is amorphous in the sense that it's hard to generalize. But given that, there are a whole slew of companies, not a whole slew, there's probably 10 or 15 companies that have established themselves as an alternative to your doctor's office, and they deliver primary care. What distinguishes them is that they're kind of digital first, so and they operate usually as like a combined health plan provider. They operate as sort of payvider type organizations. So a consumer would sign up with them, and you get an app, and you would access the healthcare system through that app. So you would set appointments, you would possibly pay premiums. A lot of times these organizations work with employers, pay premiums, you pay your co-pays, you would get any lab results. So, and the emphasis there is on convenience. And And it's this idea that it is, it's mediated through the internet as opposed to, calling up your doctor's office for appointments. So that's kind of one category. And I will say that those kinds of organizations have been far more receptive to this idea of value-based care than, in fact, almost all of them in some way, shape, or form have elements of value-based care kind of hooked into their DNA. Another that we see a lot of, because we tend to focus a lot on providers, is, and I think of these as their need in data is closely related to this idea of orders and results. So if this example just occurred to me, there is a company, it's actually located here in Boston, and it advertises in different places on TV and the internet, what have you. It has a test, a colon cancer test, but it has to be prescribed by a doctor. So they hook in different ways to EHR vendors to enable a primary care physician to enter that order. And then they take care of, they ship the test to the consumer. Consumer takes the test, puts it back in the mail, and then they will deliver the results to the PCP and to the consumer simultaneously. But there are, some of them are, analytics only. We're seeing a bunch having to do with bundles, episode-based value-based type programs. So those are two examples. This is just a little commercial for us. We are trying to get our arms around what's in this digital health bucket, because it's more and more anybody who kind of comes into healthcare from the outside is referring to themselves as a digital health vendor. So we're hoping to publish something on this topic sometime this year.
Okay. So, from what you just described, I'm still thinking back to, not that it's all about me, but I'm still thinking back to my fun with the flower vase. And I'm wondering if, one of the questions they asked me was, did I have a tetanus shot? And I think I vaguely remember, because I'm a technologist. I was an engineer in research, and then I was an engineer in the field, et cetera, et cetera. So I'm no healthcare expert. But I remember that your tetanus shots they're over a long periodicity, like every 10 years or so, it's recommended you get one. Like I can remember something from 10 years ago as to when I got that tetanus shot. But what you're saying is, in this scenario for a provider, quite possibly I would have a way of checking there on an application, because I'm using the FHIR types of APIs. Somebody could write an application that enables me to, with this provider, to check to see if I had recently had a tetanus shot, right? Yes,
absolutely. Assuming that the organizations are, have essentially agreed to make this happen. And I think more, and that particular problem that you described is actually a little bit more complicated than that. So if somebody gets admitted to a hospital, it is not unusual for every single clinician who walks through the door to talk to that patient to ask the question, why are you in the hospital? And it doesn't strike them as a strange question. The more, to bring this into the here and now, people are getting COVID vaccinations. So, and that information is mostly being reported to something called a state immunization registry, which in a theoretical sense should also have your tetanus vaccination in it as well. Not everybody has access to it. Not all states do the same sort of job in terms of maintaining these things. But I think that the COVID situation, I think, has, well, first of all, there's going to be more investment in public health. The feds have already pretty much committed to that. But I think it is causing more people to ask the question that you're asking right now. Why, why is there not more situational awareness in healthcare?
Yeah. Yeah, yeah. So I'm going to give you a lead up to another question we got from the audience. But, again, we're a technology company, as you had mentioned earlier. And as a technology company, we look at various use cases. We don't create them. So, for example, with a cloud data warehouse or a transactional database or a data integration platform, all these things which are components or elements of a healthcare data and analytics hub or a health data cloud hub, as you coin it. It can be used for preventative care. It can be used for operational management along that list of things you showed, like, looking at the contracting or looking at how your value-based program is going, et cetera, et cetera. Just wondering, from a standpoint of how data would be used in the cloud in a hub environment, do you see it fitting into supporting preventative medicine for value-based care, or do you see it going into supporting better alignment with payer and providers for operational administrative use of that clinical data, or both? Or how do you see, long term that it helping with value-based healthcare arrangements?
So I think the short answer is all of the above. The long answer is I think there are some more immediate uses or time immediate type uses in terms of payer and provider alignment. The one thing that has happened in this value-based care world is that I think is different from even, say, 2 or 3 years ago, is that there is, I mentioned that, under these programs, everybody's striving to meet certain cost targets or certain quality targets. The cost part of this is something that I think the message that they have to be looking at the same set of reports has been received. In other words, there have been enough situations where payer and provider sign one of these contracts, they're off to the races, and 6 months into it, they realize they've got, they've both got a different idea of kind of where they are from a cost performance standpoint. And, so this is obviously a problem, and there's a really, to the extent that an organization, that a provider organization is involved in one of these things, they're more strongly motivated to be on the same page than they were even 2 years ago, I think. So this idea that everybody's, I feel like, this idea of single version of the truth, doesn't really capture the complexity here. It's very difficult. At this point, payers and providers, it's clear to them what, where they really need to be on the same page. And so I feel like that is really, so a capability like what we've described here is something that can really help make that a reality. Okay. Is that responsive to?
Yeah, no, I think that's great. And just so everyone knows, we are out of time. There's a couple of questions we haven't answered. Please feel free to email us those questions. I've taken a screenshot of them. We'll try to get back with you. This will be available, the entire recording tomorrow on demand on the Xtelligent set of portal sites. Thank you so much again, Brian, for all of your knowledge that you've imparted today. I'm going to turn this back over to Vanessa now, but thank you again so much for your time, Brian.
Wonderful. Thank you both. That concludes today's Health IT Analytics presentation. Special thanks to our moderator and our speaker, Lewis and Brian, our audience, and our sponsors, Acxiom and Shellmark Research. Thank you all, and goodbye.